Alright, welcome to GIIL7, Portal Circulation and the Anatomy of the Abdominal Wall. This is Dr. Lin. Let's go ahead and get started. So the abdominal wall is not just a single static barrier. It is a dynamic structure composed of multiple muscular and fascial layers that work together to protect the abdominal by its viscera. These muscles serve as several vital functions. Stabilization, they support the lumbar vertebrae and help maintain posture. Respiration, they assist in mechanics of breathing, and also plays a role for pressure regulation. They help increase intra-abdominal pressure, which is a process that essentially helps with coughing, vomiting, defecation, childbirth. And weakness in these layers can result in abdominal hernias, whereas the abdominal contents can protrude through a weakened area of the wall. On the right, you can see kind of a subdivision of the abdominal wall, a cross-section, showing you the components from the anterior all the way down to posterior. And we have the flat anterior lateral side of the abdominal muscles on the left and right side. And on the back, we have the posterior chain showing you the lumbar vertebrae. So the boundaries of the abdominal wall. Superior boundary, this is defined by the xiphoid process and the costal cartilages of the 7th through 10th rib. On the inferior boundary, this is formed by the inguinal ligament, which extends from the anterior superior iliac spine, the ASIS, all the way down to the pubic tubercle, as well as parts of the iliac crest and also the pubic symphysis. The inguinal ligament is a critical landmark. The hernias occurring above are typically called inguinal hernias, and those below are called femoral hernias. The femoral hernias occurred more frequently in women and carry a higher risk of strangulation because the femoral canal is very narrow and also rigid. Now let's take a look at the layers of the abdominal wall. From the superficial to deep, the wall is then organized into distinct layers. The surgeons must transverse very carefully. Below the umbilicus, the subcutaneous tissue divides into two specialized layers. We have the Camper fascia, which is the superficial fatty layer, and the Scarpa fascia. This is the deep membranous layer. The Scarpa fascia is clinically significant because it contains the spread of any kind of fluids. For example, in certain kinds of urethral injuries, the urine may collect within the scarpal fascia, and then that could then spread into the abdominal wall. And beneath these, we can find the three layers of muscles, the transversalis fascia, the extraperitoneal fat, and finally the peritoneum. So over here on the right, you can see from superficial to deep, we got your skin, the Camper fascia, then the Scarpa fascia, then the deeper fascia of the superficial, intermediate, and deep layers. And on the far right, you're going to see the parietal peritoneum, and also some of the extraperitoneal fat. Sandwiched between these investing fascias is going to be the external oblique, the internal oblique, and the transverse oblique. So three layers of muscle. The musculotendinous layers. The abdominal wall gains its remarkable strength from the cross-sectional arrangement of the muscle fibers. The external oblique fibers run more inferior medially, and this is kind of referred to as the hands in the pockets alignment. The internal oblique is the middle layer, with the fibers running superior medially, perpendicular to the external layer. And we also have the transverse abdominis. This is the deepest layer with fibers running horizontally. This arrangement provides torsional strength and resistance against high intra-abdominal pressures. This is why clinically the athletes can oftentimes suffer sports hernias or strains in these layers due to high force rotational movements. Now the abdominal wall is supported by the 5 paired muscles. 3 flat muscles. These are going to be your external oblique, internal oblique, and transversus abdominis. And then paired with the 2 vertical muscles, the rectus abdominis and the pyramidalis. Together, these muscles maintain that core stability. It protects the abdominal organs and assists with any kind of movement. Weakness in these muscles can contribute to chronic lower back pain due to reduced stabilization of the lumbar spine. So on the right, you'll see the different layers. Layer 1, we have your external oblique. Layer 2, internal oblique. Layer 3, the transverse abdominis. And then on letter D, anterior posterior, we have the rectus abdominis. And then on the bottom, you'll see the transversal section. So the vertebrae is on the left, but you'll see how the muscles wrap around. Over here, we have the posterior deep chain muscles of the back. And then on the front, we have the 3 layers, 1, 2, and 3. We'll start with the rectus abdominis. This is the primary vertical muscle of the anterior wall. It originates from that pubic symphysis and inserts all the way to the 5th and 6th costal cartilages. It is segmented by tendinous intersections which prevent the muscle from bowing during contraction, and it creates that famous 6-pack appearance. Its primary function is for flexing the trunk and stabilizing the pelvis. Clinically, there's a relevant condition called diastasis recti. This is where the two rectus muscles separate along the linea alba. This can develop during pregnancy due to stretching of that midline tissue. The pyramidalis is a small triangular muscle located on the anterior to the lower part of the rectum abdominis. It originates on the pubic crest and inserts into the linea alba to help tense it up. It is actually absent in about 20% of the individuals. While it is functionally minor, surgeons kind of use this as a landmark to identify the linea alba during abdominal surgery. And because of its variability, it highlights importance in this kind of anatomy. So not every patient will have this present. The rectus sheath is this fibrous envelope that's formed by the aponeurosis of the three flap abdominal muscles. These aponeurosis and split around the rectus abdominis and create this protective sleeve. At the midline, these fibers interlace to form the famous linea alba. It's a relatively avascular structure and extends from the xiphoid process down toward the pubic symphysis. Because it contains few blood vessels and nerves, surgeons can oftentimes make a midline incision here to help minimize any bleeding and nerve damage, though the poor closure could predispose patients to incisional hernias where it could pop and rip open. So on the right, you have some of the key functions of these abdominal muscles, like supporting the movement, the pressure regulation, and of course the respiration. When considering these individual flat muscles, we must focus on clinical injury patterns. So we'll start with the external oblique muscle. This is the most outer layer, covers the internal oblique and transverse abdominis. The origin is from the external surfaces of the 5th to 12th ribs, inserts to the linea alba, the pubic tubercle, and the anterior regions of the iliac crest. The main actions are going to be for bilateral contraction. It flexes the trunk, also helps compress the abdominal contents. It also has a role for unilateral contraction and rotates the trunk to the opposite side and bends the trunk to the same side. Athletes that frequently strain this muscle during rotational sports, it becomes aponeurotic because of the midclavicular line forms the linguinal ligament. And together, we call this the digastric muscle because it works with external and internal obliques muscle altogether. On the inferior margin, it forms the inguinal ligament, also referred to as a Popart ligament. And the innervation comes from the T7 to T11 spinal nerves and also parts of your subcostal nerve. Now let's take a look at the internal oblique. This muscle helps stabilize the inguinal canal, and its aponeurosis joins the transverse abdominis to form the conjoint tendon. The weakness here can contribute to inguinal wall defects. This is that middle layer of the three flat muscles. The origin comes from the thoracic lumbar fascia, also the anterior 2/3 of the iliac crest, and the connective tissue to the lateral third of the inguinal ligament. Its insertion point goes to the borders of the 10 to 12 ribs, the linea alba, and the main action is as follows. It compresses and supports the abdominal viscera for flexing the trunk, and also rotates the trunk to the same side and bends the trunk laterally. The transverse abdominis is considered the body's natural core sod, and is heavily involved in core stabilization. Rehabilitation targeting this muscle can oftentimes be prescribed during lumbar spine injuries. This is the deepest of the three muscle. It originates from the internal surface of 7th to 12th costal cartilages, the thoracic lumbar fascia, the iliac crest, and inserts to the linea alba with the aponeurosis of the internal oblique. And the main action here is to increase the abdominal pressure, essential for forced expiration, defecation, and childbirth. The innervation comes from T6 to T12 spinal nerves and also the first lumbar nerve. Then we have the rectus abdominis. This one lies within the rectus sheath, separated by that linea alba. The origin is from the pubic symphysis and pubic crest, and inserts to the xiphoid process and also the 5th to 7th costal cartilages. The main action is for trunk flexion, so bending the trunk forward, doing sit-ups, as well as being innervated by the T6 to T12 spinal nerves. And we went over the diastasis recti, where it splits as a result of stretching alongside the linea alba. Now here is a snapshot of the key muscles, the origin, insertion, innervation, and the main action. It's very important that you know what they do and where they're supplied from. Now the dermatomes are the abdominal wall follows a very predictable pattern of the anterior rami of the spinal nerves between T7 to L1. T10, this is a key landmark for the umbilicus region, and clinically it helps physicians localize spinal cord injuries and also nerve root injuries. For example, if there's a loss of sensation at the xiphoid process, this usually indicates at a T7 level, while the loss around the umbilicus indicates damage to T10 level. So it's good to know the regions. So T7 to T9 are above the umbilicus, T10 is at the umbilicus, T11 to L1 is below the umbilicus, and L1 covers an inguinal fold in the pubic region. Now let's not forget that the main two peripheral nerves come from the iliohypogastric nerve, supplying the skin above the pubis and the upper gluteal region, and the ilioinguinal nerve that supplies the skin of the medial thigh, and of course the regions of the gonadal regions of the skin. Then the abdominal wall vasculature is supplied by a very sophisticated network of vessels, the superior epigastric artery, which is a branch of the internal thoracic artery, and also the inferior epigastric artery, which is a branch of the external iliac artery. And then these vessels then create a very key anastomotic connection between the subclavian and the external iliac systems. This provides collateral circulation. If one pathway is blocked, the surgeons must identify these vessels during any kind of operations. Some of the other key contributing arteries include the intercostal and subcostal arteries. They supply the lateral wall, the deep circumflex iliac artery from the external iliac, and also the superficial epigastric artery from the femoral artery. So the venous drainage system surrounding the umbilicus contents connect to the portal venous system within the systemic venous system via the periumbilical veins. When the portal pressure rises, that blood is then diverted into the superficial veins. They then produce certain kinds of conditions. For example, one is called the caput medusae, which is the medusa's head, which appears as if it's like radiating dilated veins around the umbilicus. And this is a classical physical finding in patients with advanced liver disease or portal hypertension. Over here is a snapshot of the key arteries of the anterior lateral abdominal wall. The origin is from the internal thoracic artery. We have the musculophrenic superior epigastric, and then we have the abdominal aorta that supplies to the 10th and 11th posterior intercostal arteries and the subcostal arteries. It should be aware of where they briefly distribute to. So for the musculophrenic, goes through the deep abdominal wall and also the hypochondriac region. Superior epigastric goes to rectus abdominis muscles, and then the 10th and 11th posterior intercostal arteries and the subcostal generally go to the lateral regions of the flank and lumbar. And over here we have the inferior epigastric that comes off of the external iliac artery, and the deep circumflex iliac artery also comes from the external iliac artery. The superficial circumflex iliac comes from the femoral artery, and superficial epigastric comes from the femoral artery as well. Now the clinical application here are the different kinds of hernias and the Hasselbalch's triangles. The Hasselbalch triangle is an anatomical landmark used to differentiate different kinds of hernias. A direct hernia passes through this triangle and it's medial to the inferior epigastric vessels due to the wall's weakness. Whereas in indirect hernias, they pass lateral to these vessels and they pass through deep into the inguinal ring. Indirect hernias are more common, overall more common in the younger males, and they follow the path of the spermatic cord or the round ligament. There are several types as well. So the neonatal umbilical hernias is due to the failure of an umbilical ring closure after birth. Usually very small and oftentimes can close. Acquired umbilical hernias are the ones that are more common in women and obese individuals, generated by an increased intra-abdominal pressure, and they can contain extraperitoneal fat and the peritoneum. Then we have the epigastric hernias that can occur along the linea alba between the xiphoid process and the umbilicus. And you'll see lobules of fat rather than the bowel being protruded, oftentimes very painful. And the Spigelian hernias are the ones that are lateral to the erectus sheath and more common in individuals over 40 years old and oftentimes associated with obesity. This is where the hernial sac composed of peritoneum, oftentimes covered by the skin, and the fat is weakened. The internal surface of the anterolateral abdominal wall. The internal surface of the abdominal wall is covered by those following layers. So we have the transversalis fascia, extraperitoneal fat, and of course the parietal peritoneum that has 5 umbilical peritoneal folds, and they pass towards the umbilicus. These folds are the median fold in the midline, 2 medial folds bilaterally, and 2 lateral folds, and then 2 umbilical peritoneal folds. So within the median fold, the underlying structures are going to be your medial umbilical ligament, or the remnant of the fetal maracus, The two medial umbilical folds are going to be the medial umbilical ligaments located on either side of the median fold, and the lateral umbilical folds are going to be what contains the inferior epigastric vessels, the arteries, and veins, and these ones do not obliterate. The umbilical folds usually refer to all of them collectively, and more specifically, they're categorized based on this, the one median, two medial, and two lateral. So this really is just one collection of them all. So really there's just 5 altogether. Now let's take a look at the inguinal ligament and the iliopubic tract. So this is a thickened fibrous band, extends from the ASIS to the pubic tubercle. The main function is that it serves as a band or reticulum that bridges that subinguinal space and holds the structures passing through the thigh. You're going to find the lacunar ligament of the Gibbernatt. This is deeper fibers passing posteriorly to the superior pubic ramus. And then we also have the pectineal ligament of the Cooper, which is lateral fibers containing along the pecten pubis. And both of these are extensions of the inguinal ligament. The first one that we talked about, the Gibbernatt, plays a role for the medial boundary, and it has a shape that's more triangular with the apex at the pubic tubercle. And the clinical significance here is that because it's a very sharp crescent free edge, it can cause strangulations of the femoral hernia. And there are times where a piece of the bowel gets stuck in this femoral hernia, and this then ligament is what cuts off the blood supply. Then we also have the pectineal ligament, which is a Cooper. This is a very strong ligament of the pelvic bone. It's much thicker and tougher, and this is because it comes from not only the pectineus muscles fascia, but also the fascia transversalis. This is considered one of the strongest ligaments in the abdominal region. And because it's so strong, this is usually the main anchor point for sutures. It's directly attached to the bone, so it's a lot stronger. And then the iliopubic tract, which is also referred to as the bandelette of Thomson, is a thickened band of the transversalis fascia that runs more deep posteriorly and parallel to the inguinal ligament. The main origin comes from the ASIS, and then it's located that forms the inferior margin of the deep inguinal region. It's unlike the collagen-heavy inguinal ligament, it's mostly elastin, higher elastin to low collagen ratio, so it's a little more flexible. And because this is more visible from the inside or a laparoscopic view, this is usually more of a landmark from the internal repairs of this region. So the clinical relevance here are that the direct inguinal hernias protrude through the inguinal triangle, through the Hasselbalch triangle. Indirect inguinal hernias pass through the deep inguinal ring, so it's more lateral. And then femoral hernias occur inferior to the inguinal ligament within the femoral canal. So usually the risk of strangulation is what makes it also a big difference. The direct inguinal hernias are usually low, whereas femoral inguinals are really, really high because of the rigidity. And then indirect are more moderate. The indirect usually happens to young children, young males, whereas direct ones are usually older due to wear and tear. And the femoral is more prone to females. Just remember, indirect is lateral, direct is more medial, and the femoral is below the inguinal ligament. Over here is a snapshot of the inguinal canal. So you can see it's about 4 centimeters long. For males, it contains the spermatic cord. For females, it contains the round ligament of the uterus. And for both sexes, you're going to include the ilioinguinal nerve and the genitofemoral branch of the genitofemoral nerve. Here are the different ways to view the inguinal canal. So the anterior wall, where you have the external oblique muscle, and then the lateral part is reinforced by the internal oblique. The posterior wall, which is then formed by the transversalis fascia, as well as the conjoint tendon. And on the roof, we have the transversalis fascia. And on the floor, we have the iliopubic tract. Now, the hepatic portal vein transport nutrient-rich but oxygen-poor blood from the GI to the liver. It is formed by the union of the superior mesenteric vein and the splenic vein, posterior to the pancreas. Within the liver, the blood passes through the sinusoids where hepatocytes process nutrients and detoxify substances before the blood exits via the hepatic veins into the inferior vena cava. 60% of the IMV drains into the splenic vein, or about 40% draining into the superior mesenteric vein. There are several anatomical locations that connect the portal and systemic systems, and they become critical during portal hypertension. So the esophageal anastomosis connects the left gastric vein where it meets the esophageal vein. The rectus anastomosis is where the superior rectal vein meets the middle and the inferior rectal veins, oftentimes confused with hemorrhoids. The paraumbilical veins meet with the epigastric vein when there's rising pressure that leads to varices, such as esophageal varices, which can then rupture and cause life-threatening bleeding. And this leads to the caput medusa, the Medusa's head, and also the retroperitoneal anastomoses of the colic, splenic, and portal veins with the retroperitoneal veins to the IVC. Because when the liver becomes scarred up, the blood cannot flow through easily. Then this leads to portal hypertension. And to compensate this, the blood finds back doors or portal systemic anastomoses to get to the systemic circulation. And these are your four main ones. So for esophageal varices, usually symptoms include vomiting blood because these dilated veins can then rupture. And on the portal side, it comes from the left gastric vein. Systemic side is going to come from the azygos vein. And then the umbilical caput medusa, which is the third one down, this is usually where there's that dilated veins around the belly button. And for the portal side, it's going to be paraumbilical vein, and the systemic side is superficial epigastric. And then, of course, for the rectal hemorrhoids in the anal canal, the portal side will be superior rectal vein, and then the systemic side will be the middle inferior rectal veins. And then the retroperitoneal, the colic lumbar, this is where there's fixed parts of the colon, mainly the ascending and descending. They touch the posterior abdominal wall. And the portal side, we have the colic veins. And the systemic side, we have the lumbar and renal veins. So usually the retroperitoneal veins refer to the lumbar and the renal veins. These two. Again, this is a snapshot of what the portal hypotension is. This is a condition characterized by the increased pressure within the hepatic portal vein, and this primarily causes cirrhosis or scarring of the liver. The pathophysiology is as follows. When the portal vein gets obstructed, the venous pressure builds up and increases. Blood then has to be diverted through these backdoor portal systemic anastomoses, and that increases the pressure that leads to these varices and potential rupturing of these small vessels. Right? So right here you can see as the blood is trying to return, it's going to be going through, and because it's going through parts of the damaged liver, the connection occurs between the systemic and the portal side. And then another clinical application area is what they call aberrant hepatic arteries. Aberrant hepatic arteries are anatomical variations where the origin, the course, and branching of the left and right hepatic arteries can be different. And there are two types. We have the right hepatic artery called the RHA, and there's also one called the LHA, left hepatic artery. The RHA is where the normal origin comes from the hepatic artery proper. This is the branch of the common hepatic artery. And the aberrant is where it mostly arises from the superior mesenteric artery. So during procedures like cholecystectomy, the aberrant RHA can be mistakenly ligated and then cause blood loss to the liver. So in this case, you can see for the right, so you can see over here for 24%, the right hepatic artery is right here. 64%, the right is behind the common hepatic duct. And for 12%, it's an actual separate branch, so not combined, so they don't converge together. And the relationships of the right hepatic artery to the portal vein, you can see right here, for about 91%, the right hepatic artery kind of works right with the hepatic portal vein. And then for 9%, it actually is underneath the hepatic portal vein. This is your typical branching of the celiac trunk. We have the right and left renal vein, superior mesenteric artery, inferior mesenteric artery on the bottom. The aberrant hepatic artery, what you'll see is that it's very different. So you have the gastroduodenal artery comes off here. And in this case, the hepatic artery may come off of the superior mesenteric artery. And then for the left hepatic artery, LHA, the normal origin comes from hepatic artery proper, but most of the times it can also arise from the left gastric. So from here or from there. Because in normal textbook, the celiac trunk gives off the common hepatic artery, which then splits into the proper hepatic artery and eventually divides to the left and right hepatic arteries. But the two main types of aberrancies is when the replaced artery, so the only source of the blood to that lobe, the standard artery is missing. So for right hepatic artery, it gets replaced RHA from the SMA, and then for the LHA, it gets replaced from the left gastric artery. Typically for the right hepatic artery, the size is typically larger and longer, and then for the left hepatic artery, typically smaller and shorter. The major branch for the right side usually will be the cystic artery, and then for the left hepatic artery aberrancy is usually going to be arteries to the caudate lobe, which are going to be oftentimes shared. And there are some cases with the right hepatic artery issue where they have the caterpillar turn, which means that the right hepatic artery is extremely tortuous and loops around close to the gallbladder, and it makes it easier to damage. Most of the time, it's always going to be behind the common hepatic duct,